Good afternoon, everyone. Welcome to our panel today on what we can do with both care and coverage for all Floridians. And before we start, I want to congratulate Speaker Tom Feeney and AIF for an extraordinarily successful conference, a sold-out event, and we have an all-star panel to kick off today. I want to start with Dr. Wolfson from the University of South Florida, public health professor. Talk to us a little bit about what the University of South Florida is doing in the Villages, one of our largest communities here in Florida, to provide a medical home, and what are some lessons we can learn from that in other contexts?
Thanks, Senator. Villages is a really exciting place to work and be. It's an integrated community consisting of one of the largest groups of people 55 years of age and older. And we've been working with the Villages for about two and a half years now. We've conducted a comprehensive health survey. And we've gotten 37,000 questionnaire responses from the 92,000 residents there. That's the single largest response of any aging-in-place community ever performed. It gives us this extraordinary wealth of information about health behaviors, health attitudes, health expectations, and health status. And without data, as we've been hearing since this morning, it's very difficult to take meaningful action with respect to policy. And from those data, we're continuing to have focus groups with people in the Villages, and we are building with them a patient-centered, primary care, medical home-driven system of care. And a great focus of that is to keep people out of the hospitals, Alan, to the extent that we can, and to manage their chronic conditions, to address their acute care conditions with preventive interventions as quickly as possible and as effectively as possible, and to work in collaboration with patients, their families, their physicians, in the most efficient system that we can define and prove it to you, the folks in Washington, and to our friends in the state.
How is that going to coordinate with Medicare?
Medicare will offer it offers several options for patients in the Villages now. It's likely that there'll be a series of special plans that the Villages will collaboratively contract with and for with large plans because they've got the leverage to do it. They've got now 92,000 individuals. They'll have 120,000 in the next 5 years. They can leverage that population to work with insurers, with managed care companies, with others to get special deals for their beneficiaries, for their residents, and those residents can then benefit from that group and the closed system, if you will, that the Village offers them in terms of care and services.
There's a lot of interest in the issue of pharmacies and how we can best provide care to citizens in Florida with their needs for prescription drugs. Talk a little bit before we jump into the hospital part of this with Alan. Talk a little bit about the role for community pharmacies, even in an area where you're dealing with close to 100,000 people.
Very important. That's why I brought my colleague Sarah Steinhardt with me, who's a new faculty member in the College of Pharmacy. She's a PharmD and a JD. And what we are doing is we are training community pharmacists with a tremendous emphasis on geriatric community pharmacy. The new pharmacists that our schools of pharmacy are training, Senator, are not folks who just sit behind the counter at the drugstore. They work in the hospital, in the community, with patients, with physicians, with nurse practitioners, with physician's assistants, all of which we need more of, and the family members to coordinate care and provide really close one-on-one and group information about how you can manage your health, your medications, and how physicians can make the most efficient and effective decisions about the best medications to use, which are not necessarily trained to do. So if we can put more community pharmacists in communities to work with physicians and families and patients and hospitals, we can be more efficient with the drugs and the medications that we spend so much money on now. And we spend a disproportionate amount of money on them, and many of them are not efficient or effective. Some of them are actually harmful.
And Alan, why don't you pick up Alan Levine with Florida president for HMA. They own and operate over 70 hospitals. I think you have about 40,000 employees. At the perch of a large hospital system, what do you see that we can do to reduce hospitalization when it's appropriate? And then also, how is moving to a DRG system in Medicaid, how is that going to affect hospitals in Florida?
Well, first of all, Senator, thank you. I have to say, with regard to the lunch speaker today, since you asked about the DRGs, he started his discussion talking about the fee-for-service system, the analogy to fee-for-service. I thought that was a great analogy. The other side of that equation is we could have capitated him and then he could have been paid to say nothing. right? And that wouldn't have been good, right? We got the benefit of the good things that he said, and so I think it's the reforms to the system are not all or nothing, and everything's not mutually exclusive. As it relates to the DRG, look, we're dealing with a 40-year irrational payment system in Medicaid that doesn't reward efficiency. And the net result is that you look at one hospital versus another and how they get paid, there is a very serious deficiency in both in terms of resource allocation, where the care is being provided, does the money follow the patient to where the care is going, as opposed to investing in bricks and mortar. And I think that is probably the right transition to make, although we want to make sure we do it cautiously so we don't have unintended consequences. The reality is, though, I mean, there's two real drivers here. You got the number of Americans over 55 is going to double in the next 20 years. Now, Florida is ground zero, so that's going to affect us in terms of the dual eligible populations as well as straight Medicare, and states are going to be hit with this. So I think from our perspective, we think, and I don't speak for my colleagues that are here from the hospital industry, but I think a rational payment system where the funding follows the consumer to the place of their choice through coverage is ultimately going to be a more rational way of distributing resources where the resources are actually needed. No one should be admitted to a hospital that shouldn't be. And there's some good things that have been done with readmissions and incentivizing hospitals to reach upstream and downstream of hospitalization, where we're responsible for things that have nothing to do with hospitalization, but we want to do things to prevent a patient from coming back within 30 days. And so those are the things that are going to engage hospitals with their communities, and the payer community is adapting to this faster than Medicare is.
Okay. Let me ask you, in terms of actual patient care, what are some of the 2 or 3 cutting-edge ideas that hospitals are using now so that when a patient is released from the hospital, that they are in the proper care of doctors and other trained professionals? What are some of the things you're doing specifically to cut down on readmissions, which are a big part of the cost in the system?
What I think you're going to see is a lot more vertical integration within the healthcare system. You'll see hospitals get involved in outpatient lines of business like home health, like hospice, like more physician practices, so that when a patient is discharged, and we begin the process of discharge planning the minute a patient actually is admitted to the hospital. We begin the process of trying to make sure they're discharged to a setting, and for instance, the biggest single driver of a readmission is noncompliance with pharmaceuticals. Somebody, particularly low-income people who do not understand what the consequences of not taking their pharmaceuticals are, they're the ones that wind up, particularly if they have a chronic disease, they're the ones that wind up back in the ER within a short period of time post-discharge. So we're actually hiring nurses that are following patients post-acute. We're trying to coordinate with home health agencies or other post-acute providers to keep the patient compliant with the regimen the doctor prescribes. You know, one of the things that I'm concerned about right now, Mr. Chairman, and I think most of the people are here, is that when you look at the cost, and what I heard from the people that were in the video, that both of the young, they're both young, and they both said the first concern was cost. Now, what's going to happen next year, I believe, based on my conversations with insurance companies, as well as what the American College of Actuaries is saying, is that we can expect young people to see 40% increases in their insurance premiums next year, at least. I've heard some insurance companies say that insurance premiums could go up as much as 300% next year because of some of the provisions that are in the ACA. And my concern with that is going to be, as the costs go up, the small group market is going to see more of a death spiral, and more people are going to opt, more young people are going to opt not to buy coverage because it's cheaper to pay the penalty. And with guaranteed issue, they can then go buy insurance when they get sick. I think that's going to drive up the cost of insurance. And my concern is, for the state, people under 133% of poverty are going to wind up flipping from private coverage into Medicaid. And you're going to see a growth in Medicaid costs as a result of that. Later, we could talk about some ideas for how we can blend some of these risk pools like Medicaid, S-CHIP, and the small group market to try to leverage those dollars. Because I think rather than just expanding the footprint of Medicaid, I think there's a way to leverage the federal and state money to buy private coverage for people and give them choice. And I think that will also help bring the cost down by leveraging these healthy populations.
All right, Stuart Slutzky, HumanaVitality, a wellness and prevention program with over 2 million members. I think 700,000 or 800,000 are seniors. And there was a longitudinal study with over 350,000 people showing almost a 20% reduction in the increase in health care for people that enrolled. When I looked at the program, it almost looks like an American Express program with different levels, and you build up points. It seems to be very popular. Could you tell the audience a little bit about the program, why it's working, and will it, over time, lead to lower costs and better health outcomes?
Sure. Thank you, Senator. And just a little bit of background. The program is called Vitality, or HumanaVitality. It was a program that was initially developed overseas in South Africa back in 1997. And the South African market, very similar to the U.S. market, has a privatized healthcare system where you have insurance companies that essentially provide benefits, insurance back to employees. And the South African market, also very similar to the U.S. market, had healthcare costs that were rising, certainly faster than inflation and beyond what people could afford. And what a company called Discovery realized, I think very similar to what's being realized here, is that to really control costs, you have to keep people out of the system in the first place. And they designed Vitality as an incentive-based program, very similar to a frequent flyer program, that rewards people and motivates people to change their behaviors around the lifestyle choices that are driving their costs. So the program starts off very simply around getting someone educated about their health, so completing a health assessment and then supplementing that with biometric screenings. And then based on that information, it creates what's called a personal pathway. So an individualized plan where we recognize that every individual that we touch has a different set of health circumstances. So people are provided support programs and motivation to engage in over 30 activities based on their health. And as they engage in those activities, which could be doing their regular preventive care screenings, exercising regularly, improving their biometric scores, they receive points. The more points they receive, the higher their status. And then points and status translate into various rewards. So the points become a currency that's spendable on an online mall. One of the things that also attracted Humana to this Vitality program is that it wasn't something that was just created overnight. It does have now globally over 5 million members and over 200 million member months of data. So from an actuarial perspective, quite a bit of credible experience to pull from. And there's been numerous studies conducted to really analyze the impact. So the study that was referenced before, our longitudinal study, looked at over 300,000 members that were included in the program for over 5 years and measured, first off, how do people increase their level of engagement over time, and really focusing on fitness. So as you provide people with incentives, are they becoming more fitness engaged? And we saw over a 70% increase in fitness engagement. And then what we did is we said, well, for those people who changed their behavior, how have we impacted their healthcare costs? And what we saw for the people who changed their behavior, a trend rate that was 40% less than those people who remained inactive. So we know that if we could provide the right incentives to individuals, and as they become engaged, that has a dramatic impact on cost.
Could you visualize a way that we could incorporate some of those concepts into our Medicaid program, which has 3.3 million of our fellow citizens get their health care through Medicaid? There aren't a lot of those type of programs. Is there a way to incorporate these private sector concepts that are working well into a program that the government runs?
Yeah, and so we've just expanded to Medicare. So you mentioned the close to 800,000 Medicare members, and we do see opportunities on the Medicaid side too, and how to take the concepts and provide better access and affordability. One of the things we just rolled out, it was actually in partnership with Walmart, is a program that we call the Vitality Healthy Food Program. So Walmart, about a year and a half ago, created what's called Great For You. So working in partnership with the USDA, FDA, and Institute of Medicine, they created formal criteria that defines which foods are healthy and which foods aren't. And those healthy foods that they call Great For You are now eligible for a 5% savings for our membership. So our intent is to take those types of programs and then expand those to the Medicaid population.
Alan?
Senator, when you voted in 2005 to pass the first phase of Medicaid reform, and I think Senator Bean is here and Representative Harrell, I thought I saw, but when you guys passed this in 2005, you actually put in place an incentive program that has the basis is already there in law and is in the waiver that's already in existence. But a lot of the ideas you just heard, we started, as you remember, very basically tying the incentives to things like HEDIS measures and if you go to the gym or if you quit smoking. But it sounds like when you get into things like going to USDA and the Agriculture Department on the SNAP program, the Supplemental Nutrition Assistance Program, and tying those incentives to what you're doing in Medicaid, I think that makes a lot of sense. It'd be a good idea.
And Dan Waldmann's the Senior Vice President for Public Affairs for Tenet. If I come to a Tenet hospital, what are some of the emerging trends? What are some of the things that Tenet's doing to make my stay there as profitable from a health point of view as possible and to reduce, to the extent medically possible, the odds of me being readmitted within 30 or 60 days?
Yeah, well, first I'll say, because the wellness activity, I hear a lot of people thinking that wellness and keeping people healthier is bad for the hospital industry. And I think that's one thing I would challenge. There's always going to be a need for acute care hospitals. We're always going to have patients, and really to the extent that there's care there that is being provided in hospitals that could be prevented, that's raising the expenditures and frankly contributing to the problem we have, which is that we're being asked to do a lot and being not paid adequately for it. So if we can make sure that things that are done in hospitals really need to be being done in hospitals and they couldn't have prevented earlier, it's much easier for us to make the argument that now we need to be paid adequately for it. So that's an important point to make. We're focusing a lot when you do have somebody who comes into a hospital to make sure that we do our part to reduce the cost, increase the value, which means providing the highest quality care possible and providing a safe environment. That involves a lot of work with physicians. I was struck by the opening presentation that talked one of the first things that was changing the environment was computers and HIT. I don't think people really appreciate how much the data revolution is really changing what goes on within hospitals. And it used to be that hospitals would be concerned about cost. A doctor would be keeping a patient in the hospital too long or would be using very expensive technology, and the conversation between the hospital CEO and the physician would go something along the lines as, wow, you're really using expensive devices, and the physician would say, it's my patient, I'm responsible for his care, get out of my face. Now we have data where we can actually show on an individual physician basis the care that physician is delivering, the resources they're using. Compare it to the physicians at that same hospital, often in the same group. Show them how many days they're in the hospital, what the cost is, and what the outcomes are. And it's amazing how it is changing the conversation. Lots of collaboration going on between physicians and hospitals now to make sure that we're really delivering the right care at the right time, doing the right thing, doing it in the most efficient way possible. And it's all been made possible by just this immense rollout of health information technology that has been happening in really the past 5 to 10 years. And that's only beginning. And I think people want everything now. We're just really scratching the surface of what we can do there.
Dr. Wolfson, why don't you briefly address the prevention element with some of what you're seeing at the University of South Florida and with your pioneering work with the villages. And then I want to segue into the second half of our panel, which has to do with healthcare coverage. So give us a couple minutes on what you're seeing from an academic perspective. And is this ever going to actually result in lower costs? I remember when I was in college, I wrote a research paper on little-known organizations called HMOs, health maintenance organizations. And there was this great promise that if we had managed care, it would lead to these great savings because people would take better care of themselves. And that hasn't materialized.
That hasn't happened.
And in a society where we don't want to have a totalitarian regime forcing people to do things that they don't want to do, we live with the consent of the governed. So these are great ideas, but how do we make them work? Do we use what some call libertarian paternalism, where we encourage people by giving them incentives? And that's, I think, what Stuart was talking about. Give us a couple minutes on what you see with the villages and your other work at USF on how we can encourage people, but in a way that's consistent with the American experience.
The villages is a great American experience, and I think it's consistent with somewhat of a libertarian model where people do things because they feel it's important for them. And you've got a highly motivated population of people who are very health conscious. And we're working with them to put in place not only a healthcare system, but an information system that allows their physicians, their hospitals, and them as individuals and family members to monitor and manage information and care about themselves. And that's what it really gets down to, Senator. Personal responsibility, how we can encourage people to become increasingly responsible for this thing, which is the most important part of the healthcare system. It's not the hospital, it's not the doctor, it's this. And the relationship that this has with the hospital and the physician is something we have to encourage, and we have to provide the vehicle for those individuals who are caring for us to make the best informed decisions. That's where electronic health information comes into play, and that's where it's not just an academic concept, but a lot of us in this room are putting in place expanded capacity to obtain data that we can use to set baselines, to look at what works, what doesn't work, and then to inform decisions through incentives and disincentives to hospitals, to providers, and even to patients and their families about what works and what doesn't work. And that's just not in the villages. That's going to happen, and it is happening across our communities as we develop the capacity to acquire useful, valid, reliable, timely data that we can share. And not just share as clinicians, but share as citizens and share as patients.
We shouldn't confuse coverage with care, and that they could end up with a Medicaid card but unable to access the system because of shortage of specialists and primary care. Do you find that argument persuasive?
Only partially persuasive, Senator.
What's that?
Only partially persuasive, I think. I think that simply giving people a card doesn't guarantee that they're going to be using it correctly. It doesn't guarantee that the system is going to treat them in a preventive, promotive fashion or care for them when they necessarily need it. And the biggest challenge is how we're going to pay for it in the first place and in the last place. Right now, we're all paying for this. And businesses in this room and businesses throughout the state are paying for it at the back end because their premium costs and the cost of their goods and services increases as a consequence of all the uncompensated and charity care that the system can't afford, and the productivity losses that they sustain not only among their own employees, but in the community where people don't work, can't work as well as we'd like them to. A healthy community is a productive and efficient and profitable community. But we don't always think that way because we're so tied in to short-term returns on investment. And the kinds of returns that we're going to see, we hope, are not the ones that we saw when you wrote your paper for HMOs, because the Health Maintenance Organization was never focused on improving and maintaining health. It was talking about capitating. It was a reimbursement system. It was insurance reform. It wasn't health care reform. And I think
let's get back to a couple people that we saw on the video and others that are in this category. Do you worry that if we expand Medicaid from 100% of poverty to 133%, that we take a precarious system, which we still have Medicaid waivers in Washington waiting. For some type of action, and we increase by 25 to 30%? Do you worry about the bad effect that it could have on other Medicaid patients, on providers?
Oh, yeah.
How do we avoid that?
Well, I think the Medicaid waiver is an important thing for us. I think they should go hand in hand. I think if Secretary Sebelius is going to ask us to increase our Medicaid population to 133%, then she should also approve the waivers and give us the flexibility as a state to do creative things in the private sector that will give us an opportunity to manage care, manage the money, and do it sensibly.
All right, let me let Alan Levine jump in on this question. One of the things that we asked for in our Medicaid waiver that's pending, that both the House and Senate agreed to, was to say, rather than treating people on Medicaid like they've got a big M stamped on their forehead in their wards of the state, why don't we treat them like fellow citizens who are having their health care compensated from a different provider? And there's no Medicaid in Japan or Switzerland or Germany. There's subsidies for people that can't afford health care coverage. We ask in our waiver that a person on Medicaid would be treated with respect like a sovereign human being and allowed to take their amount of money on Medicaid and go to the exchange and purchase their own plan for what they think is best for them and or their family. We don't know whether Washington's going to agree with that. Do you think that is a possible way to, quote unquote, expand Medicaid, but without expanding a program that's perceived as being a public assistance program?
Well, I think Jay hit it on the head. The reality is that if the federal government is going to ask the state to open the floodgates on the cost of Medicaid, that they ought to give the state the ability to have the tools to manage the program in a way that's very different than the old rules of the last 40 years. The system has changed so dramatically. I mean, when Medicaid was created, all you had was hospitals, and so all the reimbursement systems are designed around as we know, the disparate payment that occurs in the hospital world. The reality is that today's world, a lot more needs to be done in the preventive side in terms of community-based access to care. And so I think giving the state the ability to have the flexibility to manage the program in a way that provides dignity. Poor people are poor. They're not stupid. They can make choices for themselves when they're given the opportunity to make those choices. And together with that, as I said earlier, Senator, my concern, frankly, is as we talk about this new federal money that's available to the state for coverage, I would argue that whatever we do, we don't want to create a model where we incentivize people to move out of private coverage into Medicaid. And I worry that because of the massive premium increases that are coming, and they're coming, I mean, and it's not me saying this is the American Academy of Actuaries that's saying this, the very people that they were intending to help, the young people that were uninsured, even those who even though they can keep their coverage up to the age of 26, which, by the way, Florida could do before PPACA was done, the reality is that population is uninsured at twice the level as the rest of the adult uninsured. And I guess my concern is that if the penalty is lower than the cost of premiums, people are going to opt to drop their private coverage and they're going to wind up in Medicaid under 133%. That's why I think, there's a little bit, it's a little bit unique. I don't think it's been, in fact, I know it's not been done anywhere, but when you look, the whole idea of insurance is spreading of risk. The more the cost of insurance in the small group market has cost, the more young people have opted out. And then that's created the death spiral in the small group market, which has driven premiums up. If you take all of these children that are in S-CHIP and you take the TANF Medicaid population, you say we're going to provide premium support for you to buy coverage in the private market, and you expand that risk pool to include all those healthy lives, now you're leveraging the public money to bring down the cost for everyone, including small business that buys their coverage through that marketplace. This is a bigger conversation than me. You need actuaries at the table, but I think that something dramatic can be done. I think the governor's concern, and I'll stop after this, I think the governor's concern is that there are unknown costs in this thing. There's a lot of debate right now about the cost of expansion and what it'll cost. Now, it's been in the newspapers and everybody's having a feeding frenzy on that. The reality is that there really are costs that they didn't build into their models at the federal government. They extended S-CHIP to 2019, but only funded it to 2015. Well, in a couple of years, the state's either going to have to deal with paying for the expanded S-CHIP or get rid of it, or the government will fund it. The 2-year increase for primary care physicians. In 2 years, the federal funding for that goes away. Well, is the state going to cut doctors by 30%, or are they going to fund the shortfall? That's built into the funding, but they didn't price it into the cost of reform. These are costs that are real. I think if you can find a way to do it outside of the structured Medicaid program and use the private market, you'll see innovation like what you've heard from these guys.
Dan, let me ask you, and the legislature and the governor were weighing these issues, and I always thought we should have a trial before we reach a verdict, and we're looking at the numbers and hearing arguments on both sides. But take off your Tenet hat and put on your taxpayer hat for a minute. How responsible would it be for the Florida legislature to sign off on a plan where the federal government spends billions of dollars to add almost 1 million people to Medicaid here in Florida when they're borrowing 46 cents for every dollar they spend? And can we really rely on the federal government? They say they'll pay for 3 years. What if they only pay for 2 years? And at the end of 3 years, are we going to tell those 1 million people that have joined Medicaid, well, the money's run out, so you no longer have health care coverage? What are your thoughts on that from a hospital perspective?
Well, I'll address your second point first, because I think there's an extremely legitimate message that Governor Scott was bringing to HHS this week, which is there is no guarantee that there is a federal match formula for the expanded population that's in the Affordable Care Act, and states are right to question whether that's going to be the formula for the long term. And because the one Congress cannot bind the next Congress, and the Congress could go in there and change that at any time, dealing with the deficit situation. So that's a very legitimate question, and it's a message that, believe me, we have been taking back to Secretary Sebelius and saying, when you're pushing us to go lobby our state legislatures to work on and to do the Medicaid expansion, then you need you need to understand and respond to this and make sure that there's assurances. Because even when they say, well, they can drop it at any time, we all know that once it's done, it's very difficult to back off from that.
And we have to calculate the fact that it's a statistical fact that Medicaid has grown twice as fast as the rest of the budget. I mean, that's not in dispute.
Right. Now, I would also tell you, I'm from Texas, so which I guess we're last. So I'm happy to not make you last. I think the lot of competition, obviously, among states, and for this room, this is very important. You have to also question if Texas stands, or if Florida were to stand on principle and say, we don't believe this, we think the federal government is taking the entire country down the wrong path, and there are states all across the country who are moving forward with this, who are resolving the problem of the uninsured, who are taking that hidden tax for businesses off the table for having to cover the uncompensated care for the uninsured, then are we concerned that that's going to affect the long-term competitiveness of this state? Just as the governor has a legitimate question, I think that's a legitimate question that has to be debated. I would have loved to have seen the secretary give more flexibility rather than saying it's an all or nothing solution. You either do it exactly according to the ACA or you get no money whatsoever. But the fact is this is where we're going right now. And I will have to admit, we are hospitals. A Medicaid, I agree with, I think there was a quote that you had which said, at its core, Medicaid is a safety net program. It's not supposed to be a coverage expansion program. And I agree with that, but from a hospital perspective, while I would love to see more people showing up in our emergency rooms with regular commercial insurance card, and I don't know whether they're a low-income person or a high-income person, or if they got more subsidies to go to the exchange to buy their insurance or not. I'd like to see everybody have the same insurance. The table's been set right now, and we do have to make a decision pretty quickly here about where we're going to go.
But the bottom line, you'd rather have someone coming to your hospital as a patient and a customer with a Medicaid card than with nothing, right?
Yeah. I think there was the other issue too. Is if we want to get things like their Medicaid medical homes in places that are not the villages. There are places in the state where there is a high level of uninsured people. Then we need to have coverage. And you're not going to get the investment in the local healthcare system that's going to help improve people's healthcare and improve people's lives if you have people who can't afford to pay for that healthcare.
Stuart, let me ask you, and I know this is a little afield from the area that you were talking about, but you're our wellness and prevention guru for today. Do you see evidence that people that have some insurance, whether it's a Medicaid, Medicare, Healthy Kids, whatever the program is, do they, from your point of view, have better health outcomes? Do they have more of a focus on prevention and wellness and some of the things that HumanaVitality is doing? I'm always leery of people who have something telling people who don't have it that they don't need it. And so if you have health care coverage, and I'll bet you almost everyone in this room has health care coverage, I think we ought to take pause before we tell 894,000 people in Florida that they don't need it, or we can't provide it to them. We need to have a good reason, and we're looking through that. But where do you see, is there a nexus between having some coverage in health care and having better health outcomes and better health overall?
Yeah, so we believe pretty strongly that everybody should have some sort of coverage. We believe having coverage allows us to better interact with people up front, whether that's through welcome calls that you get through Medicaid, through being assigned a preventive care or a personal physician, so they're able to engage with you up front, and you're able to deploy things like case management programs. Because ultimately, I think that the comments here are important. You're paying for it today. You're paying for it in the emergency rooms, and the more proactive we could be, certainly the bigger the impact you'll have on costs. And we have seen giving people coverage does increase preventive care use. And we definitely would see an opportunity, as I expressed earlier, to couple, I think, the learnings within the privatized system with incentives and wellness and support to the Medicaid population. We think that's critical.
Okay, before we get into questions, I'd like to just take one more round, and maybe you can just jump in. With our Medicaid program, and just generally speaking with our services, and maybe Dr. Wolfson will start with you, that we provide to lower income people. I call them the Herodopolis primary care clinics. The House and Senate both agreed to them. We expanded them last year. It started out with a little over 50. Now we're close to 70 or 80. Some of these are literally located right across from emergency rooms. Some of them address mental health issues where communities decided that was what was best, and this is a partnership of state, federal, and local money. Anecdotally, I know in Lake City, I saw some evidence of lower emergency room admissions, people going to this clinic for things that weren't true emergencies. What do you see in the academic setting, and maybe each of you could jump in a minute or so if you have something on this. Are we making headway? Is there some good news, and healthcare can tend to be an apocalyptic subject matter? Is there some good news that these primary care clinics and the FQHCs that provide those services, are they reducing people just using the emergency room for primary care?
Absolutely. By providing primary care access at the community level, proximate to where people live, you're going to diffuse their need for acute care. You're going to do that because sometimes any care is better than no care, and it reduces the likelihood they're going to go to an emergency room to get unnecessary care. And then if you can bring them into primary care and identify issues that you can manage and treat, you reduce the risk of an acute episode. So there's no question that any kind of primary care that you can provide, even in a doc-in-a-box that's a private for-profit entity, and so many people in our communities are using those now, more and more. The walk-in clinics, the places in Walgreens, the folks in Walmart, use those clinics for primary care, not as their personal physician, but for something they need at that moment. It reduces the likelihood that they're going to go to the ER, and if we have FQHC clinics and other community-oriented clinics available and accessible to people, then the likelihood of their not being diagnosed or the likelihood of their having an acute episode that requires going to an emergency room is dramatically reduced. They work.
And Alan, you preside over the Florida operation of one of the largest hospital chains in the country. And so I'm sure you keep up with what's going on in hospitals in other states. And you've been an ACA secretary in 2 different states. What do you see? Are we seeing a reduction in people bringing their son or daughter at 2 in the morning to the emergency room because they haven't gotten dental care that wasn't available to them, they couldn't afford? A lot of people don't know one of the main things children are taking to the ER for are for dental issues that have gotten out of hand, lead to infections, and it's a very serious medical matter, let alone the suffering that the child has been put through in the situation. So are things better? Are they worse? Or are they about the same as they were 5 years ago?
You know, in areas where there's alternatives, I think it's better. Now, here's the challenge. Again, the concern about the Medicaid infrastructure is somebody might show up with a dental problem, a serious dental problem, but there's no dentist that will take a new Medicaid patient because of the challenges in the program. And so that's the problem with the structure. And one of the concerns I have is if there is an expansion of Medicaid and there is an expectation by consumers that they're going to be able to go see a doctor, but yet we didn't make any new doctors. We have a huge shortage of doctors, and so they're going to want to go somewhere.
But won't there be more doctors when the reimbursement rate is increased to Medicare level?
Well,
because that's the reason why a lot of doctors don't see Medicaid patients, is because it's paying 56 to 60% of what Medicare pays. In Arizona, where they pay 100%, and they've done that for many years, if you go to a tall building in Phoenix and you look around, almost 60% of the doctors that practice in the Phoenix area accept Medicaid. In Florida, it's a much smaller number. Yeah. So won't we see more primary care physicians accepting Medicaid, or is it an issue that we just don't have enough people?
Well, in primary care, you will for the 2 years that it's funded, and then obviously you'd have to fund it on an ongoing basis, but that's primary care. We talk about dental, or we're talking about other subspecialties.
Well, one thing in the dental that we did, some more good news in dental, and this was Senator Hayes' idea, and I helped him, and we got our partners in the House to agree with it. We just increased the reimbursement rate for pediatric dentists by almost 50%. And surprisingly, when you pay people for the work they do, they are more likely to do it.
Yep.
That tends to work in my job and most of your job. So we've actually seen, and this is not anecdotal, we have the statistics to back this up, we've seen a significant increase literally by hundreds and hundreds of new dentists that say, well, if you pay me something that is at least reasonable, I don't mind seeing Medicaid patients. Most people don't care where the payer source is coming from. No one has anything against people that are getting their benefits from Medicaid. So if in that 50% increase in pediatric dentistry, we've seen an increase and children being seen by their dentist. So is some of this just an issue of how we allocate resources and that we can't expect people to work for free?
Well, and I think anywhere historically, by the way, this is what I'm about to say is a credit to the legislature, because your waiver that is sitting on the Secretary's desk actually creates a model where each plan that offers services to Medicaid recipients has to have an adequacy of network. And that means they may have to pay higher rates than what Medicaid establishes. And Senator, I think we would all agree that anywhere the government has ever engaged in price fixing, it's never led to a surplus. It's always led to a deficit of service, because the government can't keep up fast enough with the marketplace, whereas the model that you've got sitting in front of the Secretary transforms the system into a market-driven model where if there's not a dentist who's willing to see a patient, that plan is going to have to pay what it takes to get a dentist into their network.
And they're going to have to pay for transportation to the dentist.
That's correct.
If there's one that's not within a certain radius of where the person lives. Your colleague and competitor over at Tenet, Dan, you wanted to jump in. Go ahead.
Colleagues, always colleagues. I was just going to add, one of the things that hasn't been discussed a lot on the primary care side is that primary care is a huge part of the solution of healthcare and access and keeping people well in this country. Unfortunately, we don't have a primary care system. It's not only about what you pay. We need a system that actually is accessible and functional as a primary care system. We have, going into primary care means office hours, from 9 to 5. Well, that's not, people need to be able to access primary care like we're seeing these minute clinics and things in CVS. I read an extremely interesting article about the experience in Spain. And Spain did healthcare reform, but they really tried to do health delivery system transformation that was all focused around community clinics that everyone used, that was multidisciplinary practitioners, and it was accessible 24/7, so that people, their front door to the healthcare system was the primary care clinic, and not the front door being a hospital emergency room because it happens to be open after they've worked their second shift and when their kid is screaming.
Can I add?
30 seconds, and then we have 10 minutes for questions. Alan, you're up.
First of all, I just want to say I saw Tenet's sign out there, that big Tenet sign.
Right.
Show off. Anyway, Dan's exactly right. When you talk about primary care, the reality is when a medical student is coming out of medical school and they see the debt cost that they're going to carry, and they're making a choice about what residency to do, they're going into specialty services. And no government tweak to the pricing is going to fix that shortage. It's the market that's going to ultimately have to fix that shortage, or you're going to have to expand, or we need to expand the ability of mid-level practitioners like nurse practitioners to be able to do more primary care to fulfill the gap, because this doubling of the age of the population over 55.
Somebody just paged one of the FMA lobbyists, but go ahead.
Sorry. Didn't mean to jump into that one.
Yeah, right at the end you jumped into scope of practice and got us in